Welcome, everyone. I'm Veronica Hood. I'm the Chief Scientific Officer for the Dravet Syndrome Foundation. I'm excited to welcome you guys to today's webinar with the team from Biocodex. We're going to be talking about the drug Diacommit, also referred to as Stiripentol. We have some of the team from Biocodex here to talk to us today. We have Kelly Gwynn, who's the Director of Medical Affairs, and Carla Shad, who is the medical officer for Biocodex. Many of you probably recognize these faces as Biocodex has been in the space for a long time, and Dr. Shad has been in the community for a very long time as well. So we're really excited to have them here today to tell us some more about Diacommit and some of the other exciting things that they have going on. Kelly, I will turn it over to you.
Yeah, absolutely. Thanks, Veronica. Can everyone hear me okay? Yep, awesome. Hi, everybody. Like Veronica said, my name is Kelly Gwynn. I am one of the directors of medical affairs here for Stiripentol or Diacommit. I am a pharmacist by training, so any questions, Carla or I definitely will be able to kind of open this up at the end and answer them as well. And then just for some background, we're going to get into access, but I'm sure some of you have heard of Panther. It is a specialty rare pharmacy, actually located in Pittsburgh, and I also used to work there, so can also answer and field some access questions as well, if anyone would have them. So I'm going to share my screen. We're going to go through a couple slides, nothing too overbearing. I know slides can be a lot, but let me just share my screen and we will get started. Sorry, guys, we're used to Teams, so Zoom, I don't know why, throws me off. Okay. Can you guys see? It should be a zebra slide. All right, cool. Okay, I think we are good. So obviously you can see Carla's name is on here, but obviously I am going to be giving the presentation today with her kind of watching over and jumping in where needed. So what we are talking about today is Stiripentol. You'll hear me call it Stiripentol a lot, but it's Diacommit when you see it in marketing materials typically. So Stiripentol actually has been around for a really long time. We're going to dive into indications and dosing and different things like that. But I like to highlight kind of where we started because I think it's really important to realize that it's been around for a very long time. You can see this super long kind of timeline here. We're not going to obviously go through all of it, but it was actually developed back in the mid 70s. And then Charlotte Dravet, obviously you can see in that 1982 box, kind of started looking at it in Dravet syndrome. And what happened was there was a large trial, it's called the STEV trial back again 30 years ago, and it looked at a lot of unmet epilepsies. And in those unmet epilepsies, there were focal epilepsy. I'm sure a lot of you have heard of that, and also Dravet syndrome. And Stiripentol or Diacommit did really well in both of those spaces. And that's when they kind of diverted and said, okay, let's really dive into this Dravet community and see how well Stiripentol works. So then you can see that was in the early 1990s. And then we had Cicla, France, and Italy, which were our first randomized controlled trials, where we have like a double-blinded, two different groups of patients on Stiripentol. These two trials, like I said, like the name shows, Stiripentol and clobazam in France and Stiripentol and clobazam in Italy, they ran parallel, had the same endpoints, had the same dosing, things like that, did really well. And then you can see it kind of became orphan drug in the USA in 2008, but actually did not become fully FDA approved in the US until 2018. So also around that same time as Epidiolex and fenfluramine, right around that 2018, 19, 20 era is when it really became available pretty widespread in the United States. But just recognizing here, I think key takeaways is just realizing that this drug has been around for a really long time. It is the standard of care in Europe and is pretty widely used actually in Europe. But just recognizing, like I said, and we're going to talk about side effects and the whole kind of picture of it, but I wanted to share this timeline aspect. Okay, again, another timeline aspect. Again, we're not going to go through all this, but also just recognizing, so Stiripentol is really kind of utilized around the globe. I think it's up to 56 countries now. So US is a subsidiary of our headquarters, which is in Paris. And we are a small but mighty team here in the United States. We're all kind of spread out, but just again, recognizing that it is It is far away. You're right. I've never been there, but Carla's been there. It is very far. But yeah, so it is all over the globe, kind of, and like I said, standard of care in other areas of the world. Okay, so kind of diving into Dravet syndrome a little bit more. So the diagnosis and development of Dravet. So we all know here on the call that Dravet syndrome is a clinical diagnosis. There's no unfortunate, yes, no, for sure testing that a patient can do. Now, I know we know about genetic testing and we're going to look at this model, but just recognizing that the diagnosis of Dravet syndrome is that clinical kind of diagnosis. So what other symptoms are they having? When is that first seizure? When is the second seizure? Do they have developmental decline? What does that look like? Now, again, we do know that 80 to 90% of patients do have that genetic mutation in the SCN1A gene. So this model was actually created about a year ago, I think, maybe 2 years ago now. I think I'm losing track of time, but this model was done by Andreas Bronkla. Some of you might have heard of it. It's a really cool tool that basically can be used to help doctors diagnose Dravet earlier and more appropriately, in my opinion. A lot of you might have heard of what's called Jeff's Plus. It's another type of epilepsy that is somewhat similar to Dravet. A lot of people report that it's not quite as severe as Dravet. It doesn't have the other comorbidities like Dravet has. It's more of a seizure disorder, more solely a seizure disorder without kind of that holistic comorbidity aspect of Dravet syndrome. So, but unfortunately, when a patient is really little, we know it's in a normal developing child. They have that first seizure, second seizure a few months later. It is difficult for physicians to decide, okay, this person has Dravet versus Jeff's Plus, and that treatment can look different. So I think one of our big pillars in medical affairs this year and last year too is earlier diagnosis and getting that kid on the correct treatment earlier. Because unfortunately, our kids are still being diagnosed, at 6, 7, 8 years old. And that's a really long time for them to be on multiple medications that might not work that well or actually might worsen that condition. So this is just a tool, nothing to really memorize. I brought it up to some of my KEEs or doctors out in the field, and a lot of them really like it. They have kind of tested it at Boston Children's is a huge level 4 center up there, and they have done further studies on this to see if it works and kind of its sensitivity as well. So really cool tool to help with that diagnosis. Okay, so a lot of you guys know this, but I do like to bring it up. Unfortunately, in this space and in this patient population, mortality rates can vary, but mortality is a topic that is a very challenging topic to speak about, but I think it's important to be aware of. So I'm sure some of you have seen this figure before, but patients with Dravet do have a high risk of SUDEP and status epilepticus being that prolonged seizure. You'll see different definitions of status in the literature. Carla has always taught me it's anything longer than 5 minutes, but some don't be alarmed if you ever see a study online that says longer than 30 minutes. People interchange that term a little bit, but just recognizing that mortality rates in Dravet syndrome can be high, with sudden unexpected death and epilepsy being that number one cause of death, and then status epilepticus as well. So another important conversation that your physician should be having with you. And again, this is one of our pillars that we're really trying to educate physicians on, and how different medications can at least help with this or help decrease seizures to potentially help with this risk as well. So it is another one of our pillars this year. So again, kind of along that same early diagnosis pillar, we have a mortality pillar as well to really try to get that education out there, because those two are just so critical in this patient population. Okay, so looking at treatment recommendations a little bit more. And if there's questions, just literally interrupt me. I can't see all of you, but just please interrupt and we can chat. So treatment recommendations, this funnel on the left, this schematic is really important in our world, right? So this was done by the International Consensus in 2022. The left one is the United States one. That right boxy figure was the EU one done a year prior. You can see they're pretty similar, but really recognizing that in the text, so it's not on this funnel, but in the actual text, and it's in the purple here, valproic acid, clobazam, stiripentol, and fenfluramine were listed as first or second line for Dravet syndrome. Now, I know a lot of you might know this, but unfortunately, these meds aren't being used as widely as really, they probably should be and are recommended. Now, this is not a true hard guideline, but it is a recommendation that experts came together, and it's a really good paper. It is available to the public as well. I know everyone on this call is extremely busy, but it is out there and available to you if you would like to read it. But yes, this is what the recommendation is: that valproic acid is first, and then fenfluramine, stiripentol, clobazam are first or second line, and then you're getting into Epidiolex, topiramate, ketogenic diet as you go down that funnel. One other call out here that I want to just touch on briefly, because I know we talked about it earlier, in that red kind of stop sign looking figure, it talks about your sodium channel blockers. So these are really important to not be on, because they actually have had the potential to make Dravet syndrome worse. So again, thinking back a few slides where we talked about early diagnosis and how important that is to get a patient on the right medication, you want to make sure that the kids are not being put on a sodium channel blocker to make their condition worse after that diagnosis, which again is why we want to diagnose as early as possible and appropriately as possible. Okay, diving into stiripentol or dicommit specifically. So, every single drug out there works a little bit differently. The three approved Dravet medications, as we all know, are dicommit or stiripentol, fenfluramine or Fintepla, and cannabidiol or Epidiolex. Now, fortunately, actually, those all work very differently. So they can kind of target seizures from different ways in the body. There's a lot of different words up here and a lot of pictures up here. But how I even explain it to the rest of my team, to doctors, is the two main mechanisms for stiripentol are it's working on the GABA A receptor, which we'll talk about, and then it affects other medications in your patient's regimen. So on this left side here, we're talking about the direct effects on the GABA A receptor. So you'll see in those three bullets, it's a positive allosteric modulator, enhances inhibition, it has a high affinity for different subunits. Its basic mechanism is to boost GABA levels. When you have a seizure disorder, typically you have an imbalance of GABA and glutamate, which, as most people know, GABA is an inhibitory neuromodulator in the body, or an inhibitory chemical in the body, whereas your glutamate is excitatory. It kind of ramps you up. So there's an imbalance in Dravet syndrome. And the body doesn't have enough of that kind of inhibitory or quiet down modulator known as GABA. So our drug is basically trying to boost those levels back up through multiple mechanisms, and kind of can get into the nitty gritty. But just recognizing that it hits it from a holistic approach. It's boosting, its binding affinities to its receptors. It's boosting the actual levels of it in the, synapse between your neurons. It's inhibiting its breakdown. So it kind of works again in a multifactorial way to increase GABA in your body to restore that balance that you're having during Dravet syndrome or any seizure disorder, to be honest with you. Then moving to the right here, it has indirect effects on other medications. So in our indication, it is indicated for the seizures associated with Dravet syndrome, in addition to clobazam. Now, how it works on clobazam, I'm sure you or your child, if you're a caregiver, you have been on clobazam at some point in time. It's a very common anti-seizure medication. Stiripentol actually has the potential to boost those clobazam levels. And it is part of its mechanism in a positive way. So it could actually make clobazam work a little bit better. And the way it does that is it basically stops its breakdown. So anything you put in your body, an enzyme is going to typically break that down. Stiripentol basically comes in and inhibits that enzyme from breaking it down. So then the level goes up. Obviously, and just to be fair, think about that it also could have a negative effect or a negative side effect, because you're adding medications together, or you're boosting medications that also have similar side effects. I think we might have had a question.
Yeah, Kelly, can you explain how stiripentol is different from a benzodiazepine?
Absolutely.
All right.
Yeah, of course. Great question. I saw a benzo question, so amazing question. Absolutely. Stiripentol and benzos both work as positive allosteric modulators of GABA, or basically I like to think of it as they lock that receptor into place, basically, for binding. The difference between them is those subunits. So you can see on this left schematic here, see the alpha, beta, gamma, all the Greek letters here. So some of these subunits are what are called localized, and some are extrasynaptic. And what that basically means is when a patient has prolonged seizures, they go into status, some of these subunits actually get turned off. It's internalized or turned off. They kind of get pulled back up into the neuron and nothing can bind to them. That is why a benzo may stop working during those periods of prolonged seizures, prolonged GTC status. Stiripentol actually binds to what's called the delta subunit, and that is an extrasynaptic subunit of the GABA receptor. So even when everything else gets turned off and there's no binding affinity, it will still be able to bind to this subunit and continue to combat seizures a little bit differently than a benzodiazepine. Does that answer your question? Yeah. Okay. And we get that all the time. I explain that to doctors very frequently, and they're like, "Oh, wow." So it's a very great question. Okay. And also too, there are other proposed mechanisms of stiripentol. So again, not included here, but just recognizing that it has a very holistic approach to attacking those seizures. It's, you'll sometimes hear people refer to it, oh, it's another GABA drug. But again, just to the point I just made about the delta subunit, it has other mechanisms as well that do try to target seizures from different ways. Okay, so diving into, again, kind of some background. One thing we just like to really highlight on this slide, I think it's a little bit busy, but just realizing it was the first drug approved in Europe by the EMA for refractory childhood epilepsy. We have almost 70,000 patient years, and I actually think this 55 is now in 56 countries. So just recognizing that it's been around a while, so we've had a lot of time to see how well does it work? Where does it work the best? And most importantly, what is its safety profile? When a drug has that long kind of lifespan, you can really see that safety profile from start to finish versus something that's only been out for a shorter amount of time. And then in the middle, I think I just talked about this. The anti-epileptic effect has 5 different mechanisms. We just talked about 2 of them that are included in our label, but there are a couple different mechanisms, like I talked about, that hit or target those seizures from different ways. All right. So this is a very busy slide as well. I always, when I present these slides, I'm like, wow, this is so busy. I like a key takeaway. But so this is our randomized controlled kind of study design. So remember that long snaky timeline, I showed Ciclo, France, and Italy back in, I believe, the 90s. So those were our original trials. This is the trial design. So you can see what was included on the left. So eligibility criteria, you had to be 3 to 18 years old. You had to have Dravet syndrome, 4 clonic or tonic-clonic seizures per month. And they also had to be on valproic and clobazam. Remember, this was done outside of the United States. Exclusion criteria, you can see in the middle there. Study here, you can see in the kind of wider pink box. So the baseline was a month period. And then the 2 months, there was no titration phase, which we're going to jump into dosing, which personally for me, I think is the most important aspect of stiripentol and dicommit, because it can be a bit challenging. But just recognizing that in our study design, there actually was not a titration phase. It was stiripentol at 50 mg per kg with valproate and clobazam for 2 months. And then there was an option for our patients to go into an open label extension period. Primary objective, you can see on the right here, was looking at the efficacy, obviously, of stiripentol. They define them as responders, and I didn't know what this word meant until I came into this space, full disclosure, but responder is someone who had a 50% or more decrease in seizures, and that will come into play in the next slide here. So looking at pooled results, this one actually I don't believe is pooled. I think the next one is pooled. So Ciclo, France, Italy, you can see the N. So 41 patients in France, 23 in Italy. So the dicommit lines in pink or graphs in pink. So about 70-ish% were considered responders. So 70-ish% had a 50% or more decrease in seizures compared to the placebo. You can see in that gray box. And then underneath, you can see the free of generalized clonic-tonic or tonic-clonic seizures over that 8-week period. Seizure freedom is a big thing that we've been talking about a lot in the field. Now, I know there are some caveats there, of course. Seizures you can't count as easily, different types of seizures. When you see literature, a lot of that seizure freedom is measured in a generalized clonic or tonic-clonic seizure, just to kind of be fair there. But we do like to kind of call that out, that seizure freedom here was possible in this type of seizures. And then diving back, I always like to pull things together, diving back into that mortality piece that we talked about. Uncontrolled GTCs is the #1 risk factor for SUDEP. So again, thinking about it from a mortality piece, if we can control seizures better, potentially decreasing that risk of mortality and SUDEP in these patients is really important. Okay, so looking at this slide again, a lot of numbers, and I feel like all of our numbers are like 70s or 50s. So I always get myself all confused and backwards. But recognizing that what a profound responder is, if you see that word profound, you're basically saying that they had a 75% or greater reduction in their seizures. So 78% of our responders, that 50% group, were actually over 75% had a decrease in seizures. I know that can kind of be a tongue twister, but just recognizing that actually it was over 50% of a reduction for most of those patients, for about a 3/4 of those patients in a pooled result of both trials together. And then this was the pooled result. Sorry, I just mentioned this, but this was talking about patients free of those GTCs. Almost 40% were seizure free in this trial population. And I will say, ever since then, not to be fair, this is our only randomized controlled trial, but in a lot of the retro studies since then, seizure freedom has been called out as an endpoint and has been fairly consistent kind of across the board over the past 30 years. And a lot of the data that I've seen and been a part of. And then to be fair, so adverse events for stiripentol, we all know on this call, you guys know way better than I do, that ASMs can have some nasty side effects, and tolerability is a huge thing. So big things to call out here would be these 4 that just were highlighted in pink. Somnolence is probably going to be the number one side effect that the patient would experience. Decreased weight, decreased appetite, ataxia, something like that. But I will say that this has been extremely consistent over those 30-year period, all the way back to, again, these were done in the 90s, to studies that were done in 2022, all the way to we're now looking at our Panther population. What are our most common side effects reported in our current patients right now in the United States? And somnolence, decreased weight, and appetite are the number one side effects reported. A lot of the side effects can be mitigated by adjusting concomitant medications. So your clobazams, your valproic acids, your fenfluramines, whatever else they're on, potentially might need a little bit of an adjustment, just like anything else. Unfortunately, it is kind of a balancing act here with a lot of these medications. Again, just like anything else, to be honest with you. But a lot of these side effects or adverse events that the patient may experience typically will, 1, subside over time, and 2, can be managed with that kind of dosing strategy and kind of working through that with your physician, which is part of my job actually in medical affairs and out in the field, really trying to educate the doctors. This is kind of what you're going to see. This is how you would mitigate that. Try not to go too fast, too slow. So a very, go low and slow approach is really important, which I think is on the next slide about dosing. Did we have a question? Carl, I see texting or typing. Nope. Okay. All right. And this was the same thing. This is literally talking about the exact same thing, withdrawal reasons and things like that. So again, you could see drowsiness, impaired seizure, lack of efficacy, obviously, is always a side effect or listed adverse event in all of these trials. I'm surprised the dosing is not in here. I apologize, but we can talk through dosing. So lastly, before I do want to chat quickly about some dosing, and I do apologize, it's not in this deck. I think either it was hidden or was in our old deck. So I do apologize. I can even pull it up. But from an access specificity standpoint, so a lot of you probably have heard of Panther. Panther Rare is our exclusive distribution pharmacy. It's actually located near me, about 5 minutes from me in Pittsburgh. So they are a exclusive distribution model. So you only can get Stiripentol in the United States from Panther. Now they have a really great team there. It is a dicommit focused team. So that means they're not allowed really to work on any other medications there, which is really great because they do become that expert. There's 4 pharmacists and 4 care coordinators that are really dedicated to that patient journey, and they do become their experts. And I like to think of them as the care coordinators are similar to our CAMs or our key account managers here at BioCodex, and their pharmacists are similar to our medical science liaisons, a medical team like myself, in sense of what they can say, the education they can provide, the data they can provide, different things like that. Don't want to go through all of this. I'm sure you guys have experienced this in the past and are familiar with different access programs. But just realizing that the patient journey there is very white glove, is the word that they use there. And I do believe that they do a decent job. They have pharmacists on call 24/7. So if you have a question, you can call 3 a.m. I used to be that pharmacist. I was on the phone in my room, figuring out the answer, and providing and talking to parents. It was very rewarding. And they also will get the prescription very quickly. So again, Dicamid is considered a stat medication there. It's one of two of the meds they distribute that is considered stat. So they do have to kind of do everything they possibly can to get that out the door at night, whether that means taking it up to USPS or driving it to the tarmac at the airport, which I have also done. So it is a very rushed, and not rushed in a bad way, but very like prioritized medication, I should say, at Panther. And you can see there's a whole program here of the intake, introduction. They help with prior authorizations. They help with clinical questions. They will help your doctor with dosing questions, things like that. So they're very involved and very knowledgeable. And then lastly on them, and I do want to quickly talk about dosing and also about one of our programs that we have through them. But we have multiple access programs. It's called BioCodex by Your Side. So you can see the 4 on the right here. So a quick start, a bridge, a patient access program, or a PAP program is like it's called, and then a copay program. These are all a little bit different. They kind of go with what the name is, obviously. They are for eligible patients. So with our Dravet patients, and Carla and I both are very passionate about this. If a patient needs med, we will get you medication. It's not really up for debate. Her and I have had multiple nights where someone will text me from Panther, just because I still have that relationship, say, hey, we need this. I'll loop Carla in, she'll approve it, and it's out the next day. So it's a very easy, seamless process. And I promise you, we are dedicated to giving that medication and getting it to you as soon as absolutely possible. And I'm sure Carla will speak on that as well, but just realizing that these are out here, and we will do everything in our power to make sure that your patient is eligible for them. Carla, I don't know if you want to chime in there.
So from that perspective, for those of you that know me, I know Gloria's on here and Veronica, and I have an ultimate promise with you all, that if this drug at any time becomes difficult for you to access, and if it's medically indicated and we're agreeing, your physician is requesting this for you, we will move mountains to make sure you have it in Dravet syndrome. That is my personal promise. The quickest turnaround I think we've had is 22 hours. So just know that this is my commitment, and it's always been my commitment in this space. Literally, if I have to fly across the country and brown bag it into you, we will get it there to you. And if it's a cost issue, we'll worry about that in the end. If insurance is being, I started to say something bad, but if insurance is being an insurance company, we have ways to bridge it until we can get to that point. So just know that our commitment, it's a little bit heavier burden for a non-Dravet patient because of some of the legal implications, but just know for a Dravet patient, we've got you, and that's my promise.
Absolutely. And to Carla's point, it does help, with our relationships there, and me using to work there and literally babysit the girl's kid, but that is over the program. So we are very close to them and very tied in. So I did want to share, of course, I got out of that. Unfortunately, I did want to share the dosing quickly, just because I think it's important to go over. And then one last thing in Pantherland that I wanted to share with the group. So just quickly, if you guys don't mind, we have like a couple minutes, I'm sure, to go over this dosing. And I apologize for it not being in that deck. I think that was my fault, so I apologize. So Stiripentol's dosing, again, can be a bit of a scare for some physicians, but it's really, honest to God, not that difficult in my opinion, and in Carla's as well. So just realizing the USPI does recommend 50 mg per kg a day in 2 to 3 divided doses. Now, we all on this call probably realize that a titration should be necessary and should be recommended. The schematic you see here on the left with the green and other colors, this is actually the EU dosing. So this is what is recommended in Europe. So you can see it's a gradual titration. So starting at that bottom, so everyone starts on 20 mg per kg per day, and then bumping up based on their age. The younger the child, they actually can tolerate it more due to a metabolism standpoint. So you can bump them up a little bit quicker versus an older patient. you might want to go at a little bit of a slower pace. To be honest with you, when I'm out in the field discussing this with doctors, I always try to reassure them that this is not like a black and white thing where you absolutely have to do this, or if you don't, it won't work. I tell them to do what they're comfortable with. So you're 10, 15, 20. I have a doctor in New Orleans who she likes to start on 25. Whatever that works with them, their patient's caregiver, what your comfortability is, what the other meds they're on, that's huge. To be honest with you, and you can see that on the right here. So just realizing that, the dosing is a little bit, kind of like a trial and error type of situation, just like a lot of other ASMs, but recognizing that a titration is truly recommended and what would be best for the patient for a tolerability and efficacy perspective. And then lastly, on dosing, before we kind of switch back to Panther, I apologize. I know we talked about this a lot today, but unfortunately, a lot of ASMs interact with each other. You all know that. I'm sure you've experienced that. A doctor will add a new med, and then the patient has excess somnolence, excess, decreased weight or appetite. And like I shared with you earlier, Stiripentol does interact with a few different medications, clobazam being one of them. Now, while it's part of its mechanism and can be a positive, it also can be a negative, to be fair, and it can cause some excess somnolence. So again, the recommendation is to decrease your clobazam dose by about 25%. And again, that looks different by the doctor, to be honest with you. I've learned that in the field that some do it right away, some do it after they experience that. It really just depends on, again, what dose the patient's on, what their comfortability is, what their tolerance is to clobazam. I've really noticed that a lot. Some patients will come and say, my child couldn't tolerate clobazam at all, and that's okay. But others might be able to tolerate it at a little bit of a higher dose as well. And then finally, valproic acid, no real, in my opinion, drug-drug interaction with Stiripentol, maybe a little bit. It's more of an additive side effect thing. So it's not really increasing your valproate like it does the clobazam, but they both have the same side effects. So that decreased weight and appetite. So again, realizing, oh, I'm on both of these medications, one of them probably should be decreased. If you're adding Stiripentol to a valproic acid regimen, you typically should decrease it by about 30%. And again, we are educating our doctors on this. This is very widely available to them. Go, Carla.
Yeah, I was going to just say to you all on the call, I know that you guys are unbelievable advocates for your children. And so with this, it's ironic. Some of the people that I actually train with, I've even turned to them and asked them why they've gotten suddenly so dumb over the last 20 years, because suddenly this drug is an enigma to them because the label is such. We are always taught to go low, go slow, and to titrate based off of efficacy and tolerability. That suddenly gets lost with this. So from my perspective with you guys is, one, be patient. This is not going to be a miracle cure overnight. There are some patients that respond very, very quickly, but also give it time, and to sort of allow those side effects to sort of level out a little bit, because you guys are very used to what this looks like, and you know what your guys' children's baseline is. So advocate with your docs and just say, hey, I know that we maybe need to go slower, or we may need to adjust some of the background medications, but how can we do that together? So to me, I think this is not just an autocratic decision by your provider. You guys need to weigh in on this as well and know that there's more than one way to skin a cat. And I think for every patient, the titration and management of con medications are all different. And from this perspective, when you have one patient, you have one patient, and decisions need to be based off of that individual patient.
Yeah, absolutely. Last thing, and then I think we will have lots of time, Veronica, if that's okay with you, for some questions. So guys, last thing I wanted to bring up, and full caveat, this is only for Stiripentol patients right now. So Carla and I and the rest of our team, again, one of those other pillars that we really are, prioritizing this year is quality of life, because we do recognize that Dravet syndrome it affects all aspects of lives. It affects your lives. So we do recognize that it is, a piece of data or a piece of information that is very important to learn more about. So we created a quality of life survey that goes out to new patients who are prescribed Stiripentol through Panther. Carl actually has a letter that we included in each shipment that kind of is literally written from her, that says, this is why we want to do it. This is what we're doing with this. Please, if you have some time to fill it out, and then you can kind of opt in through Panther as a QR code. It's very easy and kind of seamless. I know you guys are probably asked to do a million surveys, so we do recognize that as well. So I understand 100%. But just realizing this is out here, these first 13 are answered by Panther, so you wouldn't fill out any of those. Those are all from like your patient's profile or the doctor's prescription. It's more these ones, where you are being asked, seizure frequency, your length of seizure. I'm talking about ER and hospital visits, rescue medications, different motor skills, speech, gait, communication, feeding and eating behaviors, different sleeping schedules. So really kind of trying to understand what that baseline is, and then looking at it kind of in a holistic, how is it changing over time, whether that's in a positive or negative way.
Yeah.
Carly,
And for those of you guys that know me, you can tell that I wrote this, so it's a little bit all scattered all over the place. Because a lot of the quality of life that we get, and this is where I've learned it from this community, some of the quality of life standards don't matter. And I try to implement things that might matter to you all. And I know, with Gabrielle Conacher and all that group and the Inchstones Project, trying to bring things in. Just because you have a change, what is that change actually being perceived by you all? So, from my perspective, this has been very slow to enroll because we're only opening this to new start patients because I'd like to have a true baseline. But if you or any of your friends in this, organization, other parents out there, try to advocate for this because this is the one thing that we really have some paucity in data is a lot of pharma companies do, is how this is really affecting the patient and the family for that matter. So just something to, a little plug here, and just know if you read this survey, know it's a little crazy because it's written by me. Uh, so just go, it's scattered, but guess what? So am I. But I'm trying to find things that are relevant to your community.
yeah. All right, I think that's all we had. I definitely want to leave some time, Veronica, for questions, or if you have anything. I hope this was helpful, but I can also answer any questions.
Yeah, thank you both so much. And Carla, it might be scattered, but I think the other thing you are is passionate, and I think hopefully that also comes
Thank you.
through. I think there were just two things in the chat that got answered, but I thought would be good just to say out loud because I hear these similar questions from the community a lot. One was asking about, I don't think we hit this out loud, but the formulation. I know there's been talk about the intention to work towards a liquid formulation. And so can you talk a little bit more about?
Yeah, so that's definitely in our development, and for those of you that have been watching sort of the tuberous sclerosis side of things with vigabatrin went from very similar formulation of like a sachet, something that you had to mix, and I know it's a pain in the rear end for mixing, especially whenever you have a smaller children. So we know there's an unmet need, and it actually it's beneficial to have more accurate titrations, especially for those smaller children. So it is in development. It's going slower than I wanted it to be, and I have no control over that, unfortunately. But I keep advocating that we need this because you guys need to have something that's easier to use rather than having to open up a sachet, mix it in some volume of water, and trying to do math. We don't need you guys doing math. We want you guys to be able to have that defined for you. So from this perspective, and this is the actual last update that I got from headquarters yesterday. We have to do a shelf stability study, which should be done based off of the information that I'm getting. The shelf stability study should be done probably by in the next 6 months. And then from there, we're looking at potentially a new launch of this product here in the U.S. And this will primarily be a U.S. product only for this formulation around mid-year 2027. So that's about a year later than I was hoping for. So I always learned that, with pharma, add another 6 months to 12 months on what your end goal is, but we're still very passionate about that. And what we've seen from the tuberous sclerosis space that going from Vigadrone to Vigafide has been a great impact for families. Because I think people disregard how much of an issue it is to reformulate a powder.
Yeah, I think actually we just got a question in the chat that's reflective of just that sort of thing. So Elise has said that her 10-month-old was just prescribed Stiripentol and they haven't yet started it. So here's someone who hopefully will also consider filling out the quality of life survey as they start. But her question is that it's recommended to dissolve the sachet in 100 mils of water and then give that to her. And that feels like that amount would just be nearly impossible. Is there a smaller or a more minimum volume that can be used per
It's,
sachet?
I'll let Kelly address this, but this is from my perspective on the sachets. Use whatever you can to get this into your child consistently. So that is this volume of water, and if you guys think about it, even with our super young children, 100 cc's of water, of free water, is actually can be dangerous depending on how often you're giving it. So Kelly's got a really good response that they get from Panther, but my simple advice, you put it in whatever. I'm not quite sure if your child's even taking baby food at this point. That could actually be something to consider. But Kelly, go ahead from the pharmacy perspective.
Yeah, absolutely. So to Carla's point, NRPI, to be fair, does say 100 milliliters and then swish with another 25. You truly don't need to do that. I've seen most in 10 mLs, 15 mLs. There's a really nice real world paper out there, and I know no one has time to read anything. I totally get it, but Dr. Willis wrote a really good paper, and in his paper it says 10 to 15 mLs for each packet, and that dissolves it pretty well. We also get questions about breast milk and formula, because obviously in that patient population, I'm not sure if that's your child, but in the PI, it also says to avoid dairy. To Carla's point, you can give it in dairy as well. There were no real true studies with dairy like that. So yes, I would say you do not need to use the 100 milliliters. Definitely check with your doctor, of course, just to be fair. But yes, we typically in the field, from my medical perspective, and then the pharmacist at Panther, they'll typically say 10, 15, 20, whatever you're comfortable with is fine.
Great.
Okay, thank you so much. That answers my question completely.
Yeah, of course. I thought I saw another one in here.
The 6-year-old that's having increased seizures, Kelly, we need. So let me ask you, have the generalized seizures improved to the point that you may be seeing some these more frequently because they're just more apparent, or do you actually believe that there is a true increase in this? Feel free to.
Tanya.
So Karen, is it you?
Oh, I'm Karen, but no, I think the question is from Tanya. So, but Tanya, you're muted if you're trying to speak.
If right now isn't a good time to come off mute and you
Yeah,
don't feel like
Tanya.
that answer, just reach out and we can make sure we
Yeah,
get the rest
yeah,
of.
Tanya, I put my email in the chat, so happy to talk about you. I can just tell you that in general, with any, obviously with any anti-seizure medication, if you're benefiting one seizure, sometimes you either one becomes more visible because you've been focusing more on the quote unquote hard seizures, and then it's also not impossible that you can see a new breakthrough of seizures. Not to say, that could be a possibility here, but also recognize too that Stiripentol has been studied in both focal seizures and absence. Just sort of ancillary, there's data related to that. But like I said, with a patient, one patient is one patient, and an adverse event in any given situation is possible. So happy to talk to you offline about that. Not a problem.
Great, thank you.
I think I saw one about the QR code for the survey. Great question. I'm not sure if you're a new patient at Panther or not. I'm not allowed to share the QR code just because it can't come from like our company, to be fair. So I can put you in touch with one of the pharmacists. I don't know if you're a new patient there but it is only for them specifically, and it is I should say, I'm wording this really poorly, but it's specific to that patient, to that profile, you know what I mean? So we can't just like blindly share it But
All right. Great. I think that's all that we have in the chat. I think from everything I see, we've got answers to everything. Thank you so much, Carla and Kelly, for being here and talking to us about this today. Thank you to everyone who joined and for asking questions. If you're watching this as a recording and you have a question, you can reach out to the team at Biocodex or you can reach out to DSF. I'm always accessible, Veronica at dravetfoundation.org, and I will get you connected to the right people to get answers to your questions. So thank you so much, everyone. And with that, I will hopefully see many of you in the near future. Thank you.
Thank you, Veronica.
thank you,
Good seeing
everybody.
everyone.
Have a
Thank
good
you.